Everybody, thank you very much for joining us again. The topic today is going to be on cognitive behavioral therapy, often abbreviated CBT, and how it applies to this population of individuals that we are working with in a rehab setting. We're going to cover the what, the why, and the who. So what exactly is CBT? Why is it important to consider as a therapeutic mode with this population? And within the population, what individuals typically would you be looking to apply this to? So let's start with the what of CBT. CBT is again, cognitive behavioral therapy. We talked last time in the ACT presentation, if you heard that one, as it was a third line. It was a third line therapy when it comes to behavioral therapy being the initial orientation that you're often familiar with from the standpoint of Skinner and some other kind of early 40s, 50s psychologists. Cognitive behavioral therapy evolved into the 50s and 60s, associated with several names: Beck Ellis, David Clark, David Barlow. These are individuals who really felt that behavioral therapy in and of itself did not fully encompass the aspects that human beings bring to the table when it comes to why do we do the things we do. They wanted to include the process of our thoughts and how are our thoughts involved in driving our emotions. It's a relationship between our internal state, or what is going on inside of our brain, and how that is externally manifested in our actions and our behaviors. Very much so, it addresses the role of the automatic belief systems. What are the core beliefs that you have within your subconscious that cause you to act and react in the way that you do? And as we'll talk about several times throughout this presentation, you can consider it almost a black box kind of theory. In other words, you've got this black box, you can't see inside of it, but when you put something into it, something comes out the other side and it's been changed. And so it's inferring what is going on inside of that black box by what you can observe, by what comes out. And so from the standpoint of the cognitive aspects of this theory, you can observe people's actions, you can have people report their emotions, but what is important to understand is where are those coming from? What are the aspects within that person's thought system that results in those particular actions or those particular thoughts or behaviors? And the theory itself is really looking at how can we address these maladaptive or problematic behaviors. If you look at it from the standpoint of a behavior management strategy or an alteration of mood strategy, if you're looking to intervene with someone who's coming to you for kind of trying to alleviate whatever distress they are experiencing, you're trying to identify what are these maladaptive or irrational or destructive thought processes that the individual has that is resulting in these behaviors. And it's attempting to address these through a systematic and goal-oriented process. And again, this is important from the standpoint of working with rehab patients, because again, we often have a limited amount of time, particularly from the standpoint of inpatient therapy, or even in some cases from the standpoint of outpatient contact. We have a limited number of contacts. We have a limited amount of time with an individual. And so we want to have a therapeutic process that is targeted to a very specific group of thoughts, behaviors, actions, or emotions. And it needs to be a time-limited process. It needs to be goal-oriented, specifically targeting something, and it needs to be time-limited. Because it's not a never-ending process. And ideally, like many of the psychological interventions, the goal here is to teach the patient, to teach the resident, to teach the client, to basically enact these therapeutic interventions on their own. You eventually want your therapist's voice to be replaced with their own voice inside of their head, so that they are able to apply what they have learned to new situations as they come along, and not have to go back to the therapist every time something comes up to address it. And again, the goal is changing those internal beliefs so that our behaviors, our emotions, and our thoughts better match our goals. Again, we talked about this from the standpoint of ACT, of being aligned with your values, identifying what it is that an individual values truly and using that as a compass, as a direction. So again, if you can align your thoughts better with your goals and desires, and again, from the standpoint of the world in which we live, and we'll be talking about that here shortly, is how these cognitive distortions often involve a kind of misappropriation of how the world actually is. And if you expect the world to be different than it is, a lot of the time you're going to end up frustrated because the world is probably not going to bend to your will. And so as a result, we have to learn to change our own expectations and more readily adapt to reality. Traditional behavior therapy really emphasized the role of stimulus and response. In other words, in a given situation, there is a stimulus, there is some action that occurs, or there is some situation that gets our attention, and that stimulus causes us to react in a certain way. So that is the stimulus and response. When A happens, then B is the response. Cognitive behavioral therapy took that a little step further, which is to say that there is an intervening factor here which must be considered, and that is the individual's core beliefs, that black box I was talking about earlier. So it's not simply stimulus and response, but stimulus in the context of our core beliefs, which then influence our response. So in the role of cognitive behavior therapy, as a therapist, we have to realize that our patients don't react to the world, they react to their perceptions of the world. And that is true for all of us. Our perceptions are our reality. You have to remember that your brain, this thinking and reacting and emotion generating machine, is basically this jello-like substance that's locked away inside of your skull and doesn't have direct access to the world. It gets information through our senses and then causes us to react in a certain way through our own learning history and experience. And those learning histories and experiences include our own histories as well as information that others have given us. These form our perceptions, which ultimately form these core beliefs. These core beliefs are believed to be operating at a subconscious level. They're not directly observable. They're not directly within our conscious control. So it is a set of rules that we carry within our head. It is the code by which our brain interprets information and operates. And so if you can alter that code, you can change the way in which you think, feel, and react. And so becoming aware of that certainly is the first step. The belief here certainly is that our core beliefs are responsible for our thoughts and actions, more so than the real world, because again, it is our perceptions that are our reality. So it's not just a situation that you react to, you also react to your internal core beliefs. You know, we see that from the standpoint of a school setting. In other words, if you go in and you tell a teacher that this student right here is particularly bright, but this other student here is not very sharp, if you treat people in that way, if the teacher treats the students in that way, it tends to become a self-fulfilling prophecy. If you have expectations, you tend to treat things in that way. In the same way that if somebody tells you that when you walk through that door in just a moment, there's somebody on the other side that's going to jump out and try to scare the heck out of you. You are likely to be a little bit anxious walking through the door because you're anticipating that somebody's going to jump out and frighten you. So the fact of the matter is that that situation has not yet occurred and may not even occur if somebody's pulling a joke on you. There may not be anybody on the other side of the door, but you're going to react as if there is, because your perception now is that that is what the reality of the situation that exists. So these core beliefs, again, they're automatic, and they cause us to act and react in ways in which we feel perfectly justified on the basis of assumptions from which these automatic thoughts and emotions arise. So these automatic thoughts really do shape our emotions and our conscious thoughts and behaviors. So again, from the black box standpoint, being able to see what is inside that black box is impossible, but you can infer that by looking at how is it influencing the information that's going in and coming back out. Now, when it comes to our core beliefs, and when it comes to what's inside of that black box, if that black box is supportive of what you want in your goals in your life and it makes you happy and content, then that is wonderful. You probably don't need to seek out a counselor or a psychologist, because most people don't go to a psychologist and say, I'm really happy, but I think I could probably be happier. Can you help me with that? It tends to be, I've got something in my life that I'm miserable about, miserable enough that I'm going to come and see you and see if you can help me change that. That's the one thing that is a little bit different about working with a population of individuals in a rehab setting as a psychologist. Very few people come to QLI because they want to meet a psychologist. They come here because they've had a severe injury. They want to get their life back. But the role of psychology is a little bit different at QLI and at other rehab facilities, because from a psychology standpoint, from a therapy standpoint, you're dealing with a population that may not be necessarily aware of those issues and certainly did not come there just to seek out your services. But for most psychologists working in more of a community-based setting, in working with individuals that you would consider the walking well, who have some aspect of distress or aspect about their life that they want to change, you know, those core beliefs are resulting in some degree of distress or unhappiness, or they're interfering with the person attaining the goals that they want in their life. And so that's the point at which you say, okay, what can we do to change this? What can we do to alter this aspect of function? The core beliefs that influence our thoughts and actions, in terms of how Albert Ellis and some others actually looked at theorizing about these core beliefs, they basically divided them into three main domains of distortions that color our perceptions. And of course, these perceptions drive our thoughts, they drive our emotions, and they drive our actions. You know, the first of which is a distorted view of self. In other words, I have an idea of myself or expectations that result in me changing how I feel about myself. In other words, typically a negative evaluation of self. The rules such as, you know, I feel that I am unlovable or I'm ineffective, that distorted view of self, and often attributing negative thoughts to others about ourselves. In other words, that's one of the biggest issues when it comes to public speaking. People are nervous and anxious about speaking in public because, well, I'm going to say something stupid and an entire room full of people are now going to know that I'm an idiot, and everybody's going to think that, you know, I'm worthless. And so my own self-evaluation is going to be that I'm right now at least assumed to be a normal human being, but if I get up there and say something stupid, everybody's going to know that I'm not very bright. And so as a result, there's a lot of anxiety about getting in front of a group of people and talking. If you had a different view of self that was not so reliant on others giving you positive praise, you might not be quite so anxious about that. So it's having that sense of self be less tied to those expectations and perceptions. So again, the fear of public speaking is not that someone has done that, it's that that might happen, the possibility of that saying something stupid and then being evaluated in a negative light. Again, that perception that exists is that person's reality. So that distorted view of self of being ineffective or unlovable or everybody else has to like me results typically in depression and anxiety. What you tend to see with that when it comes to that distorted view of self is the individual symptoms tend to be focused more toward depression, social withdrawal being one of those symptoms. Common symptoms associated with depression as well are, you know, tearfulness, sleep and appetite changes, that filtering out any positive experiences as well. We know that from a neurological perspective and a behavioral perspective, An individual who's experiencing depression is quite attuned to negative experiences. They tend to focus on the negative because the negative is more easily observable under those conditions. Another of the triad is a distorted view of the world or others, and that is that the world is hostile, the world's out to get me, or one that I think I and a lot of people tend to have, which is, the world should be orderly and predictable. Despite the fact that for most of our lives, what we have experienced is the world tends to be unfair and do things for its own reasons and doesn't really take into account what I want. We still expect that things will happen the way that we think they should happen and that things will be orderly and predictable. So despite living a life in a very dynamic, chaotic environment in which things are constantly changing, we seem to have an expectation that things are always going to be the same and that they are going to be logical, follow a sequential, predictable fashion and come out the way that we expect. So despite all evidence to the contrary, we tend to continue to hold on to that and make plans as if that is the way the world is. And if the world is not like that, and I hate to tell you this, but it's not, well, what happens is people tend to be mostly angry and frustrated. Think of the 4-year-old in the store who's not getting what they want. How do they react? Well, emotionally inside of our heads, most of us react like that 4-year-old when we don't get what we want. Now, socially, we might be a little bit better at hiding it, but the bottom line is that we expect to get what we want when we want it. And if we don't, we tend to be fairly well put out. So if you expect the world's going to give you what you want when you want it, you're going to spend a lot of time being put out. And so when you see anger and frustration, that tends to be a hint that the cognitive distortions that are underlying this person's emotional reactions is one of the expectation that things should be the way that I expect them to be and be predictable. A distorted view of the future is kind of the third leg of that triad, and that's the fallacy of permanence, that nothing is ever going to work out. It will always be like this. We tend to feel, again, in a world that changes constantly, most of us tend to feel at any given time that things are going to continue the way that they are right now. That every song that could ever be written has been written. Nobody could ever come up with something new, despite the fact that we're constantly writing new music. That everything that could be invented and make our lives easier has already been created. Well, that's not true either. We keep coming up with new technology and new inventive things, even simple things that you would go, well, why didn't somebody think of that before? Well, it hasn't existed previously. Things are constantly changing. And so by the same nature, when someone is experiencing something in a negative light, if somebody has had a severe injury and they're in the process of going through rehab for it, and it's a difficult and arduous process, it's a marathon, oftentimes the emotional reaction to that is that things are never going to get any better. Things are always going to be like this. So again, despite all the evidence to the contrary, that the world is constantly changing and our lives are constantly changing, that we have that belief that things will never be better. And if you're in a bad place, if emotionally you're in a difficult spot, feeling like the world is never going to get better is going to result in a lot of anxiety. It's going to result in a lot of worry, just fretting about the situation and the potential expectation, or at least a perception, that things are always going to be like this. That results often in a difficulty with initiation. It's hard to get the energy to get up and move and do something if you feel like, well, it's not going to have an effect. Things aren't going to get any better anyway, so why should I put effort into it? That learned helplessness response of inaction, I think, is a direct consequence of that expectation that nothing is going to change, so why bother? When in fact things do change. If things in your life right now are bad, they're likely to change in a positive direction. Now, I hate to tell you this, but if things in your life are perfect right now, there's only one way for them to go, and that's things are going to get worse. Things change. If they're bad, they tend to get better. If they're great, they tend to get worse. But it does tend to bounce back and forth between those. And again, if you have a realistic expectation that that is the case, then you're going to have less of an emotional reaction when things do change. Again, if your life is perfect and all of a sudden something comes along that's not perfect, that's not a catastrophe. It's just the way the world is. And if you accept that and expect that, you're going to be less upset that things are less perfect than they used to be. So that identification of what symptom is presented and being able to figure out what type of cognitive distortion is there helps a cognitive behavioral therapist start to figure out a little bit of a roadmap of how should we address this particular issue. What is the general type of approach that is going to be helpful with this person and the issue that they are dealing with. Now, one that you run into often is that is associated with that distorted sense of self, which is I have to be liked by everybody. And the absolute here is I have to. In other words, if I have 1,000 friends and one of them for some reason doesn't like me or says that I did something that is wrong, then all of a sudden, well, I must be worthless because this one person has found something about me that they don't like. So if everybody doesn't like me, I'm no good. I have to do what others want so they'll like me. If you are in a management position, or if you're in a position where you're making decisions that may potentially impact other people, this is one that is going to be really difficult if you have this as a core belief, because some decisions that you make are not going to be everybody's favorite decision. Sometimes the decisions that are necessary are not popular. But if you're in a management position and you feel like I have to make decisions that is going to make everybody happy, you're probably not going to make a lot of decisions. You're going to end up just kind of frozen because I can't take a step in this direction or that direction, because either way I'm going to make somebody unhappy. So there are situations in which everybody doesn't win. And so in those situations, as a manager, you have to make the decision that is best for the values and the goals of the organization or the individual that you are deciding for. If you're making a business decision, you have to make a decision that is in the best interest of the business as a whole, not what makes everybody happy. So effective leaders tend to be ones who make the decisions that are best supportive of the values and the goals of the organization, not ones that make everybody happy. Now, again, you're not out to try and upset folks. You're simply not really taking that as the first and foremost issue when it comes to the importance of what type of decision to make. One big one that, like I said, I think a lot of people tend to have is that the world needs to be predictable and orderly. And that 4-year-old expectation that things should happen when I want them to happen right this damn minute, and I should get what I want when I want it. The world should be there to serve me. And in fact, the world is not particularly interested in you if the world even knows that you exist. The world is not there to make you happy. The world is not there to give you what you want, and other people rarely think about you as often as you think other people think about you. As a matter of fact, your own mother doesn't think about you as often as you think she does. You know, most people, when you're doing a presentation, again, most people think, okay, they're thinking about me, they're evaluating everything I see. Most of you right now are thinking about the things you've got to do later today. Some of you are thinking about what you're going to do this weekend, and a couple of you are thinking about a vacation you've got 2 months from now. You know, you're not thinking about me right now as much as I would think that you're thinking about me. So again, that focus that the world should give you what you want is an irrational expectation. And if your expectation is that the world should treat you the way that you want to be treated, you're going to spend a lot of time angry and frustrated because, again, the world doesn't operate that way. If you can more closely align your expectation that sometimes you're going to get what you want if you work toward it, and sometimes you're not, that is a more realistic expectation. That way, when you don't get what you want, you're less likely to react with anger and frustration. You redouble your efforts and you work a little bit harder for what it is that you want to achieve. But even that doesn't guarantee it, because that's the way the world is. Irrational thoughts tend to often be associated with absolutes. And so as a therapist, when you start to hear some of these words as you see highlighted here, must, should, nothing, never, always, these are absolutes. And quite frankly, the world often doesn't have a lot of absolutes. It's not ones and zeros as exist within a binary computer system. It tends to be shades of gray in between. So things rarely exist in perfection or complete absence. They exist in some variation of that. And as a result, if you're not looking for absolutes, you tend to be a little bit more flexible. Friendships, for example, individuals who have a diagnosis of a borderline personality disorder tend to have people in their life that they feel are their best friends or their worst enemies, and there's not a lot of in between. And if you ever cross that person, if you ever do anything that would suggest that you're not their best friend, then suddenly you flip over to the other list, because there's only two lists there. There's best friends and there's worst enemies. And so if you expect things from the standpoint of those absolutes, it is going to be really, really difficult. So I must be perfect at everything. That is an irrational expectation. No one is going to be perfect at everything. And if you have that expectation, the first time that you are not perfect at something, it is disproving that you are perfect. And so as a result, your self-evaluation goes in a very negative light. Now, I think it's realistic to be aware of our capacities and what we are able to do. And we can even take credit for things that we might be good at. But to say that I have to be perfect at everything is an irrational expectation that no one can live up to. And so as a result, having that as a belief system is going to cause you to have a very negative self-evaluation. All of us are aware of our own weaknesses and foibles, and so as a result, we always have the capacity to make those negative self-evaluations. To say that nothing is going to work out is also an irrational thought. Some things will. Some things will work out even without any effort on your part, and some things will work out just because it falls in your lap. When that happens, be happy. It doesn't happen like that all the time. But to say that nothing is going to work out is an irrational expectation. So for all of it, for all of these irrational thoughts, these are, again, these are signals, these are alerts that there might be an irrational thought process behind what someone says if they say, I'll never live this down, or this is never going to get any better, or I have to, or I must. These are all statements that suggest the underlying presence of an irrational thought, or what Ellis would call a cognitive distortion. These irrational thoughts or cognitive distortions can result in us filtering things as well. As I said earlier, when individuals are clinically depressed, they tend to have a great deal of difficulty seeing the positive. As a matter of fact, their brain is attuned to the negative. It's almost like tuning a radio to a frequency. When you do that, it tunes out the other frequencies. And the reason that you do that is so that you can more clearly pick up one particular frequency. Well, when it comes to depression, our brains get very attuned to negative experiences, and so as a result, in a situation which is half good and half bad, we'll see all the bad. It's the glass half empty. It's looking at the empty part. So, being able to even rationalize things that are positive. You have heard folks before, well, yeah, I got a good grade on that, but that grade really doesn't matter because, that person grades easy anyway. So being able to discount the positives when they occur rather than reveling in them and celebrating them. One that a lot of people share, and I think probably everybody listening has this one tucked away somewhere deep inside of that black box, which is the irrational thought of, I know what other people are thinking. You are a terrible mind reader. I hate to tell you that, but you are. If you've ever objectively tried to prove that by walking up to strangers on the street and telling them what they're thinking, they're probably going to inform you that you're wrong on many occasions. Now, sometimes you're right, but most of the time you're not. And when you're right, it's going to be luck more often than it is actual knowledge. Again, our perceptions flavor our world to the point that our perceptions are our reality. So if you think that someone is thinking something, you are now going to act and react toward that person as if that was the truth, as if that was what the other person is actually thinking. We call this attribution theory in psychology, which is we tend to attribute beliefs and feelings and even intent to other people's actions. Now, you cannot see a belief and you cannot see a feeling and you cannot see an intention, but you can see an action. And so when you see an action, you tend to impose on it the expected and perceived beliefs, feelings, and intention. If you have ever been cut off in traffic, you have engaged in attribution theory. You have given that person a reason why they did that. You have determined what their intention was in cutting you off, and you have now reacted, often with anger, because the person did that to you. So again, that is irrational because you do not know why the person did that. Great example that psychologists that I used to work with had was when you're sitting at a red light and the light turns green and the car in front of you doesn't move. And so you sit there for a little while and eventually you blow the horn and the car doesn't move and you sit through the whole light and they're still sitting there. So at that point, you're very angry and frustrated. The light turned green and you didn't move. You know, you might even get to the point of getting out of your car and walking up and tapping on the window. And when the windows roll down and the woman looks at you and says, "My baby's not breathing," all of a sudden your world changes. Your perception is different. You have different information at that point. You're no longer reacting with anger. You're now a helper. So, you know, that type of situation is just illustrative of the fact that a reaction at any given moment is your perception of the world. And it's only when you actually have data that you're able to make an informed decision. So when you assume that you know what other people are thinking and you base your reactions on those assumptions, you're going to be wrong more often than you are right. So it is irrational. The magical thinking is everything would be better if. And so that is, if I had more money, if I had more hair, if I had a better car, then things would be wonderful. What are you laughing at? Okay, yeah, okay, I don't have a lot of hair, okay? So, you know, if these things were different, well, no, you know, the classic, wherever you go, there you are. Living in a different place doesn't make your life radically different because it's your life. You are there living that life. And so you have to change you, not your location when it comes to that. So all of these things are ways in which we have these irrational thoughts within our brain. In other words, we have these unrealistic expectations. The double standards when toward the bottom is one that I encounter frequently in working with clients in a rehab setting. I feel that I'm a burden to my family because I've had this injury. And so I ask the question, which is to look at, does this go both ways? If it was your wife that was injured, would you feel like your wife is a burden? And invariably they say, well, no, of course not. I would want to be helpful. Well, why don't you attribute that feeling to your spouse, that this is an opportunity for them to be helpful? The other is on the bottom corner there, the fallacy of fairness. And again, it goes back to the fact that the world is not fair. There is no great scale anywhere that's going to balance things out. The world is simply what it is. And if you expect that reality, that the world is simply what it is, and that it's not fair, then you're going to be less angry and you're going to be less frustrated. You challenge these thoughts to develop insight and to change that code inside the black box. You want to dispute those irrational thoughts through experiences and replace them with a rational expectation that is more aligned with the way that things are. So it's experiencing, as most of us have as adults, that the world isn't fair, that we're not always going to get our way. And so, you know, as opposed to a 4-year-old who hasn't had those experiences of the world not being fair quite as often, we have a better, keener developed sense of the fact that the world's not fair. And so as a result, as adults, you're a little bit more able to deal with it appropriately when things don't happen the way that you want them to. The process of conducting CBT really is one of trying to figure out, from an assessment standpoint, what types of distortions are there, educating the individual as to the process of reconceptualizing and more closely aligning with reality, acquisition of skills, which can be taught in a variety of different fashions. And that acquisition of skills often, as I'm going to talk about shortly, involves homework. It involves experiencing things, trying things out, generalizing and maintaining that, and then follow-up skills. This process really is to teach the patient the process itself. It's guiding the individual in their understanding of these automatic thoughts and helping them identify what are those underlying core beliefs that are resulting in that. And then through experiences, teaching the patient to dispute those, changing those thoughts and beliefs with rational alternatives. And the homework, assignments, and practice and repetition are what's most important. As it comes with learning any skill, repetition helps things become more solidified within our brain. It's not enough to just be aware of that irrational thought process. Otherwise, me saying to you the world isn't fair would completely fix your expectation that the world should give you what you want when you want it. And I'm betting that some of you still have those expectations. I do occasionally as well. Most of the change that a patient experiences in this therapeutic process occurs as they have experiences between sessions. And so there are a variety of different techniques and ways that you can do this. It's reading and reflecting on others' experiences. It's logging and reflecting on your own experiences. And it is real world situations. I mean, there were some interesting ones. Ellis was a fun therapist, I think, and he had a very direct style. He had a patient who felt that when she, on a college campus, when she went out in public, people were evaluating her in a negative light. They were judging her. And part of what he did with her was to say, you know, if people do judge you in a negative light, so what? You know, it's not going to kill you. You're not going to die. And so he actually gave her assignments that were kind of, you would consider odd. So I want you to walk across campus with a banana tied to a string tied to the back of your pants. So you're going to be dragging a banana behind you. So people are going to notice that, right? But you know what happens? A crowd doesn't gather. You don't have 50 people following around pointing and laughing. People look and then they go on about their business, and you don't die. It is not the expectation that you have in your head of what is going to happen in those situations. A friend of mine who was filming something for our facility actually pulled me in to help a couple of years ago, and we were going to the mall in Hawaiian shirts and flip-flops and zinc oxide on the nose in February to film this particular thing. And we almost convinced ourselves that we're probably going to get arrested for doing this, because you shouldn't be in flip-flops and Hawaiian shirts with zinc oxide on your nose at the mall in February in Nebraska. You know what happened when we went there? People glanced at us, but they went on about their business. Nobody followed us around pointing and laughing. We didn't have a SWAT team show up and throw us into a car. We went in and we filmed and we walked out and nothing happened. So all of our fears of people are going to think we're idiots or we're likely to get arrested for this didn't come true. So that experience actually allowed us to learn. That experiment was testing a hypothesis, which was, if we do A, then B is going to occur. We did A, B didn't occur, so we had to change our expectation. All right, let's jump to the why. Why do we need CBT when it comes to a rehab population? First and foremost is depression after brain injury is very, very common, and for a variety of reasons. So, you know, just the situation itself, my life has suddenly substantially changed because of this injury. My abilities have changed. My neurotransmitters have changed because of damage that has occurred within my brain. I've got, you know, nodes of communication within my brain that have been disrupted as a result of this. And so neurological causes and certainly social. We don't exist within an island. We have social connections, and we have a sense of self and identity that's dependent upon those connections. And so all of those changes result in depression after brain injury. You also have to be aware of the fact that there's a great deal of variability in the manifestation of depression after brain injury. It doesn't always present in the classic DSM fashion. So difficulties with self-monitoring and self-awareness or deficits in memory can make it difficult for somebody to have an ongoing sense of how they are doing and what their mood has been like. So even being able to report that. As a clinician in a rehab population for depression, you have to look at other indicators. So loss of sleep and appetite, which are classic symptoms of depression, are also very much associated with brain injury. Disruption of sleep cycles, changes in appetite, secondary to changes of sense and smell and taste. So what is more helpful is to actually talk with caregivers, to talk with families about whether or not the individual is demonstrating a lack of pleasure engaging in activities that otherwise would have been pleasurable for them prior to injury. So be aware of that kind of complex link between depression and aggression as well. People are disinhibited often after frontal brain injuries, and so that might not necessarily represent a symptom of depression as much as it neurologically reflects a lack of being able to inhibit those impulses or behaviors. You have to be aware of the fact that there is a high incidence rate of depression after brain injury. Within a normal population, you're typically talking about 7 to 15% rates of incidence for individuals with clinical depression, but between 27 to 61% in various studies have been reported to develop diagnosable depression as a result of traumatic brain injury. And what is important to take into account as well is these diagnosable means it has to fulfill all of the diagnostic criteria for depression. There are a large number of individuals who have depressive symptoms that are at a subclinical or subdiagnostic level that may very well experience these secondary to the variety of factors. Again, the situational, the social, the neurocognitive changes. It's important because depression following brain injury is associated with poor outcomes. This is a big why. So, why treat depression? Well, because not treating it results in poor outcomes. The reason that we're in the business of doing rehab is we want to improve people's functioning and independence and get them back to a life that they can value and enjoy after an injury. So if there is anything that's going to get in the way of that, you want to make sure that that is being treated to the degree that it can be. Also, be aware of the fact that other neurobehavioral challenges like anxiety or aggression can be exacerbated by the presence of depression, particularly in a younger population. In adolescents and in young adults, depression may not manifest in the same way as it does in an older population. In an older adult population, being able to identify depression by tearfulness, by depressed mood, by lack of initiation is relatively an accurate diagnostic criteria group to look for. But in adolescents, rebellion and aggression may be much more common, and you see that as well with young adults with disinhibition after brain injury. So just be aware that it can manifest differently. So diagnosing that is important. When it comes to anxiety disorders following brain injury, there is an overlap between a lot of post-concussive symptoms and the core symptoms of generalized anxiety disorder. Things like being restless, feeling on edge, being easily fatigued, difficulty concentrating. Again, if you have difficulty with attention or memory, that's going to present as difficulty concentrating. It might be anxiety, or it might simply neurologically be the disruption of those core neural systems that are involved in that cognitive ability. What's important to know is if the individual did not exhibit such symptoms prior to the brain injury, then clearly the symptoms that are manifested, if they are traditional anxiety symptoms, are the result of the injury itself or the neurological changes associated with that brain injury. With individuals who have mild to moderate brain injuries, anxiety as a primary symptom is one that is not uncommon. In other words, it is relatively common to see anxiety manifested at a rate which is diagnosable from a DSM criteria measure, but that did not exist prior to that injury. Now, if you have an individual who did have a diagnosed anxiety disorder prior to injury, certainly the neurological changes can result in exacerbation of that anxiety. It can be worsened as a result. Quick question associated here: are there statistics for people who have had a TBI and pre-existing depression? Does the TBI typically worsen? I assume the depression. Or does it sometimes improve premorbid depression? That's a complicated question, because what you tend to see after recovery from injury, again, this is a little further down the road, is much higher rates for depression post-injury. For individuals who have depression pre-injury, as they recover back to their baseline, those symptoms are likely to emerge. If depression as a primary symptom, or whatever symptoms they exhibited of that depression, are not present after a brain injury, it is typically because the neural substrates necessary to exhibit those symptoms have been compromised to the point that those symptoms are not present. As the person does further recover neurologically, you tend to see a reacquisition of that presentation. So in other words, if a person was depressed previously, it is highly likely that they will be depressed post-injury as well. Again, superimposed now with the sociological factors and identity factors that are now changed, which also make it more likely that the person will experience those symptoms. There is an increase in obsessive compulsive disorder with reference to a general population, and an increase in post-traumatic stress disorder, particularly for individuals who have mild to moderate injuries. And this is one interesting aspect when it comes to brain injury. PTSD, or post-traumatic stress disorder, and brain injury, there's a rather complex relationship there. Individuals with mild injuries are more likely to demonstrate PTSD. There's some evidence emerging that individuals with a loss of consciousness of greater than 15 minutes have reduced rates of PTSD, and this is believed to be cognitively associated with the fact that if you do not recall your injury, then you do not have knowledge or experience of the trauma itself. So as a result, there is an absence of post-traumatic stress disorder. For individuals who do recall their injury, they are much more likely to experience PTSD. If you've survived a severe life-threatening situation, but you are not aware of that situation because of the memory loss associated with your injury, you're less likely to have that emotional reactivity to it. So the who is who benefits from this. So again, individuals with a pre-injury history of depression are at greater risk to develop depression after TBI. So you want to make sure that these individuals are getting those resources regardless of whether or not they present with symptoms at the time of their rehab. Individuals typically are going to have decreased cognitive reserve for dealing with that. And again, the filtering that we talked about earlier is going to be present as well. And as we've discussed, individuals without a pre-injury history of depression are more at risk for developing depression after brain injury than the general population. We know that CBT is one of the most empirically well-supported interventions or treatments for depression in a general population. It is for brain injury as well, but you sometimes have to adapt it to this population. So studies demonstrate a similar utility in brain injury as well. And again, from the standpoint, as we've talked about previously, from chronic pain, a cognitive behavioral therapy of ACT, or acceptance and commitment therapy, is a first order level of treatment. Treatment for depression, the numbers show in research that treatment is effective, as it is with the general population, for dealing with depression and anxiety. It's important because it is goal-oriented, it is targeted to a specific set of issues with which you are dealing, and the process fits what we know about neuroplasticity. Lots of repetition is going to be helpful. It also fits into a model of integrated interdisciplinary teaching and training because all aspects of your therapy need to be focused not just on being able to button your shirt and say "ba ba ba," but also the expectations and the perceptions that are associated with whatever level of functioning that you are able to exhibit. From the standpoint of our conceptual understanding of neuroplasticity, the ability of our brain to change in response to experiences, this also aligns well with CBT. We are changing our internal code in how we perceive things by those experiences, and repetition, repetition, repetition. The process is enhanced by engagement. If the person wants to be a part of that and enjoys participating in it, you're going to get more repetition. So something that somebody is seeking out. Like most therapies, though, it is not necessarily something that will generalize. If you target a specific type of thought process, if you target a specific behavior, it may not well generalize to other aspects. But as a therapist, your goal is to teach those more broad skills that an individual can utilize. It also doesn't fix everything. So, as are many therapies, it is targeted to a certain type of issue, particularly those perceptions that we carry around, but it is not a first order treatment for everything. It's important to take into account with a brain injury population the degree to which their own self-awareness is there. Again, we have to have a common acceptance of reality in order to engage in this as a therapeutic process. And with a greater severity of injury, there's a more likely greaterhood for compromised awareness. Now, the vast majority of brain injuries fall in the mild to moderate range of severity, which means the intervening effect of awareness is going to be with a relatively small population of individuals who have the most severe injuries. So right hemisphere neural substrate injuries, as well as bilateral frontal injuries, often result in some compromise of awareness. And so being able to identify that as to whether or not this person is an appropriate candidate, which is also a question there that just came up. How do you identify a person who will participate in benefit? How do you know if they're ready for change? A person can experience that change through life experiences, regardless of their degree of readiness and awareness. And so that's one of the benefits there, is the ability of a person to change through experiences. That's part of what that homework is. If the person can overtly engage in the talk therapy of being able to respond and challenge some of those thought processes, certainly that is ideal for the traditional application of CBT. But you can also arrange experiences for a person through which they gain some of that knowledge without necessarily the overt pointing out that this is something that you have learned. Adaptations that are necessary with this population of individuals after injury would be those that are listed here, particularly the increased repetition and using reminders, handouts, and notes, being able to focus on those things. It's breaking things up into smaller chunks and presenting it with a degree of repetition that allows you to be able to engage in that. There are some questions that have looked at, what is the dose response here? On average, about 400 minutes of therapy are needed for maintenance in studies that have looked at this and broken it down from the standpoint of how many hours of therapy. Typically around 8 to 12 sessions would be typical in a community-based setting for a CBT application. But with this population, certainly you have to look at the variance of the individuals and the degree to which they are cognitively capable of acquiring this information. For anxiety and depression after stroke, one study found that around 6 to 8 60-minute individual sessions was effective with change. Studies really haven't identified the needed degree of sessions or minutes in a formula setting with this population. And I think that's always going to be a challenge with a brain injury population, because brain injury is not a unitary construct. It is not a single thing. It is different for every person. And so as a result, that individual therapy process is likely to be different. A couple of questions that have popped up: the average length of time or sessions for CBT with the patient. It can vary anywhere from 15 minutes to 60 minutes. I think in an outpatient setting, typically you would have 50-minute sessions. But in an environment like QLI, where I have access to the clients throughout the therapy day, I think being able to pop in at times when they're working with someone else and helping provide that additional structure and support is also helpful. One of the questions is, what profession typically provides CBT? Again, training in CBT, you are likely to experience if you're training as a psychologist or if you're training as a counselor. But it is also not magic, and so it is something that can certainly be supported throughout other therapies as well. So we really try, from the standpoint of all of our clinical staff, to have them knowledgeable of it and be aware of what it is that we are working on, so that other therapists can be a benefit to that as well, can be an adjunctive therapist when it comes to that. And one other question was, can CBT be helpful 10 years of injury to date? In other words, if you have someone who's had an injury several years ago, CBT, I think, can be helpful to any of us who have the capacity of conceptualizing that we have these underlying thought processes that influence our behaviors. I think when you begin to challenge that, and when you begin to take experiences that change that, with or without an injury at any point in our life, it can be helpful in changing how we react when we become consciously aware of why we're doing what we do. Got a couple of minutes left, so I'm going to turn it back over to Mike to get our questions that he needs to have answered. Thank you very much for your attention through this, and please send me questions if you've got them.